we'll we'll have some questions and answers, and I'll solicit some answers, and we can have a discussion rather than a didactic talk on pulmonary stenosis, which is a relatively simple lesion. So let's start with the first slide. So can somebody answer this question? It's very interesting, this slide. If you think of how people did pulmonary valvotomy, you have to know that it is one of the first ever interventions to be done in the field of pediatric cardiology. The first was balloon atrial septostomy. Oh God. So definitely it was not the first in that sense, but it was right up there amongst the first procedures to be done. So who will answer this question? And it's a very important history question. You got to know it because everybody thought about it very well. Sem, Khan, Rubio Alvarez, and Jim Locke. So I don't have anybody answering. I'm going to have guys. How do I get chats? Yeah, is somebody answering from the listeners, or do we have participants elsewhere? Question. Does anyone know the answer to this question? Okay. Locke is not the answer. Locke did a lot of things for the first time. Khan, you're guessing, but in reality, that's actually not a correct answer. So the correct answer is very interesting. In the human being, it was Sem, and he doesn't get credit, as often happens with people from outside of the United States. Sem is from Norway or Sweden, I forget which Scandinavian country, but what he did, he's a radiologist. He inflated a balloon catheter inside the PA and pulled it down like a balloon septostomy and tore a pulmonary valve and reported it in a radiology journal. So it was reported in cardiovascular radiology and didn't really, register. What happened then was, it was quoted a lot, but nobody registered it in 1979. 1982, it was Jean Khan. She was working in Johns Hopkins, and she thought of balloon, the technique, the way we do it, which is to put a guide wire and take a balloon on top of the guide wire. And this was 1982. And around that time, Dr. Locke reported a lot of new things. 83, he reported coarctation, peripheral PS, everything he reported. But that is when, if you search very hard, there is a Spanish publication by this guy called Rubio Alvarez. In 1953, he took a blade catheter and actually tore the pulmonary valve. But the report is in Spanish and the details are really not clear. But he thought of it before all these people thought of it. The problem is the diagnostics were very poor. So the next question is this. And this is an important one as well. Who did it the first time in India? And India wasn't far behind. With interventions, the world's first pulmonary balloon valvotomy happened in 1982. We were ready in 86, it happened. 85, the patients who selected, and 86, it happened at All India Institute. So Dr. Savitri Srivastava. So she did it, and I was there when it was done. I was an MD student, and she did pulmonary and mitral and presented it in the grand rounds. And it was quite an event because first interventions really happened in the country at that point of time. And you have to think from the perspective of the era and the fact that nobody had done it before. To actually go and do it for you, it's so commonplace, everybody does it. But to think of it at that time and actually do it was revolutionary. So, just as a question of history, so you needed to know that. Okay, so clinical spectrum of congenital valvular PS. It's important to recognize, I think that window, I don't know what do I do about that. That's coming on the screen there, but it's not coming here, right? Oh, I have no idea. I have no way of doing anything to that. Okay. NB host, it's chat one. So I'm just going to close the chat window and then I think it will come up. Okay. So fetal essentially you need to recognize that younger the patient is, the more severe the disease at the presentation. The more severe is the RV involvement, the more severe is the RVH, the smaller is the RV, and the greater is the level of likelihood of progression to PA-IVS in fetal life, for example, if you diagnose, and the worse is the response to treatment. So it's very simple. You can expect more severe disease, less responsive disease in the younger age groups. So if older patients, you can have syncope, but the real problem happens to be heart failure if it is very severe. And you don't get to see that very often. Infant, it is cyanosis plus or minus heart failure. In the newborn, you can have a small RV, you can have RVH, you can have cyanosis, but you can have duct-dependent pulmonary circulation. And in the fetal life, it's tending to progress to a duct-dependent pulmonary atresia. Okay, so what are these two types? What are these two slides showing? No, you are not allowed to answer. So, describe the features of dysplastic pulmonary valve. You can, you know it. There are 5 features. See this picture, you'll get it. It's a dysplastic valve, and what makes it dysplastic? No, that is not completely opening, is right here. So, anyways, because what you say will not be heard by the class. You're going to get away with a lot of not answering. Here it is. So, a typical valve will have preserved more mobility. Dysplastic will have reduced mobility. The dysplastic valve opens at its base. The typical stenosis opens at its apex. It domes. This one remains as it is and just opens like this. So the difference in the opening styles of the two valves is very important to recognize, and you can understand why one doesn't respond, the other responds. And then in a typical pulmonary stenosis, annulus is normal. It's often reduced in a dysplastic valve. It may not be Z-score of -2, but it will be not so great. It will be around 1.5 Z-scores. Supravalvular tethering. So if you go back to the previous slide, this is what is known as supravalvular tethering, where you have the commissures fused with the wall of the MPA. And at that portion, the MPA is all written. So supravalvular tethering is present in this dysplastic valve. It's absent in typical pulmonary stenosis. Post-stenotic dilatation is often present in typical, but you tend to see it in older patients. And dysplastic, it is absent. Auscultation, you have this inconstant click, which is more in expiration, less in inspiration. And in dysplastic, you don't have a click typically. Associated syndromes, I've just reversed it by mistake. The Noonan, Alagil, Williams are all examples where you get to see dysplastic valves and you don't have anything in the typical. I have reversed it by mistake. And again, the last two columns, the results of BPV is excellent in typical and poor in dysplastic. So the last two columns have been reversed. Sorry for that. So it's important to identify. And you can actually identify all features of dysplastic valve on echo, and you can actually talk to the parents. Very simple. You have a valve that is very thick, that is not moving, that is moving at the base towards the annulus, and that has tethering, post-stenotic dilatation, mild PR. All that is suggesting dysplastic valve in a patient who has Noonan syndrome. You have to tell the parents, I'm not so sure there will be a response to this or not. Whereas if you have a typical dome-shaped valve, you can be more optimistic. Okay? So clinical features. What happens to S1? So you think it's in strict phonocardiac terms, it is normal. But what do you hear? Have you thought of it? You hear it, it's basically variable. Why is it variable with respiration? So if you have very severe PS, the click is fused with S1. And when click is fused with S1, S1 becomes louder in expiration, softer in inspiration. You have an inconstant click in pulmonary stenosis. Do you understand the problem? Inconstant click, you have to go and read it. You have to read all these things and check it out. So inconstant click will be something that is louder in expiration, softer in inspiration. In inspiration, the RV cavity is full. The valve gets pushed up. Now, when the RV contracts, it doesn't have much more to get pushed up. So it doesn't click, doesn't give you that sound. Whereas in expiration, the valve comes down, the RV is less full, now has more excursion. So you have the inconstant click. You should learn and listen. It's very easily picked up. The inconstant click, when it's very severe PS, the inconstant click moves very close to the first heart sound. And it becomes fused with the first heart sound. And it's louder, S1 is louder, in expiration, softer in inspiration. So the click part of it I explained. The murmur. Yeah, so what are the features of the murmur vis-a-vis tetralogy? So the murmur of tetralogy, as the severity goes up, the murmur becomes softer. Whereas typically with PS, the murmur becomes longer and louder till a point where there is a substantial decline in right ventricular output. So until that point, you have a fairly prominent and increasingly prominent and longer murmur. S2. So wide variable split with a soft P2. I think that is always discernible in a valvular PS. So these are all features that you should be knowing as far as valvular PS is concerned. Okay, here's the question. Which of the following examples of asymptomatic patients with isolated valvular PS would you follow most closely? And it's a very simple question which everybody should get right. So I want some people to answer. I'm not able to find answers. Let me see if the chat screen appears. It doesn't appear on my. So somebody answered, thickened valves. And that's next question. I want answer to this 1, 2, 3, 4. Can people answer? Can you see the question displayed so you can easily answer? Can somebody answer here? So answer is 1. 3. Lots of people are saying 3. But Soumya is absolutely right. The answer is 1 because the level of unpredictability is highest with valvular PS in newborns. 1. 2. The cost of missing is also the most. If you make an error and the patient progresses rapidly and develops a complication, it's likely to be doing far more damage. Now, 30 gradient in a Noonan's dysplastic valve is not going to progress very rapidly. And it's very important to recognize that the essence of the statement I'm making is the younger the patient, the more serious is the natural history, and you need to follow more closely, and the more unpredictable is the natural history. So that's the point that I was trying to make. Okay? So a lot of people answered 3, but that 3 is incorrect. The answer is 1. Okay, survival as a whole in the group of asymptomatic. You take in asymptomatic 100 patients with asymptomatic valvular PS, the entire spectrum. How is the survival? Can anybody answer? So there's a natural history study that shows the survival is exactly the same as the normal population. So as a whole, asymptomatic valvular PS is actually a benign disease. You need not panic, and just because you got a gradient of 60 in the echo room, say next day you need to be posted for a balloon dilatation. That's incorrect. So it's not different from the general population. And who then is at risk of progression of adverse events? Just as I said, younger patients, neonates and infants, when the PS is really severe, more than 80, okay, and those with cardiomegaly. So they found in the natural history study, these 3 categories had events. They were in small numbers, so they didn't affect the whole group's survival, but these 3 categories are really bad in terms of overall outcomes as compared to the rest. Okay, what are the indications? Is somebody going to give me gradient thresholds? Newborn. When would you, let's start with not newborn, let's start with older patients. Let's take a 6-year-old child. At what gradient would you intervene and why?
About 50.
So that's the standard teaching. 50 is the standard teaching. Somebody said 60. Actually, I like that answer. But the books say 50. And 50 is the gradient. If you do by Doppler, I've had several patients where the Doppler gradient was 50, 55. I've taken them to the cath lab and really got nothing in terms of pullback. So you need to combine that 50 or 60 with features of right ventricular hypertrophy, with auscultation that matches the echo, with maybe some right ventricular hypertrophy on ECG. Then you feel pretty sound in going forward to balloon dilating the valve. Otherwise, you can get an isolated Doppler can fool you quite often. Infants, you would dilate at what gradient? Infants, you could have a higher threshold. I mean, 40, 50, you can watch and follow. If everything is really well and the child is doing supremely well, you need not rush to intervene in that child. You can keep following. And the indications in infants could be, one, if the gradient goes above, I tend to wait till the gradients go above 70 or 80 in infants. I don't have to intervene at a relatively lower gradient. But more importantly, if they develop stenosis, if they develop features of severe right ventricular hypertrophy, or if there is significant right atrial dilatation, then I start getting worried. So I look at the other features also. With newborns, you got to have strong reasons to intervene because the procedure is risky in newborns. You can't just take an asymptomatic newborn with moderate PS and say I'll balloon. That's not correct. In a newborn, you have to have severe PS. Otherwise, it's not ethical or appropriate to intervene because the risk of procedure is greater than the risk of doing nothing. Then you're violating the first rule of medicine. So you should do something in a newborn if there is definitely with duct-dependent systemic circulation, there is heart failure, the child is blue, fine. All those things are acceptable indications. But the child is pink, if there is, unless the gradients are really high, above 80 or 90, then I think you can watch and see how the child does and choose a time when it's appropriate to intervene, but you have to watch very closely. So that's the way I would approach these patients. The evaluation checklist. So we're going to talk about balloon pulmonary valvotomy as such because that's kind of what happens is that if the phone rings, then I lose internet connection. Kavita, are you able to hear me? Kavita? All right. So I'm going to tell you about the next question is evaluation checklist, which is essentially doing a clinical examination, measuring the saturation, doing an X-ray and ECG. They're all very essential. They can't be bypassed because they need to correlate with your echo finding. It's very important. And in the newborn, the saturations are particularly important. And we need to have some specific echo checklists for newborn, infants, and older children that I'll go through. And it's interesting to go through these checklists. So what does echo enable really is, one, it enables you to first think of the procedure. What balloon size, what trouble do you anticipate, all those things. And also enables you to predict outcomes. So you can tell the parents what you expect, both immediate and late. And I think it's important that you communicate all this before the procedure. The other important thing is to identify your high-risk subsets. I think there are two really high-risk subsets as far as valvular PS is concerned. One is the newborn and infant with critical PS, which is the commoner subset these days. But the subset that you guys haven't seen very much, that we have done a fair bit earlier, was older children with heart failure. This is a very difficult subset. So the newborn with critical PS, there is a fairly important checklist, and you need to be conscious of it. Firstly, atrial septum. And by and large, 99% will have a PFO. But if they don't, it's actually worse, because then you really can have a situation where the patient can fall apart during the balloon dilation. So it's very important to have a PFO because it enables you to do a much safer procedure. The tricuspid valve is important. Measure the annulus, report the Z-score. If you have a low Z-score, even with critical PS, then the response is not going to be good. Both immediate and long term, we need to consider PDA stenting on the same procedure. The valve itself may not be normal, even if the annulus is okay. You can have TS, you can have a doming tricuspid valve, you can have severe TR, which will then impact the way you cross the tricuspid valve. So if you have severe TR, it's very difficult to cross the valve. TS will come in the way of your outcomes. So that's also there. RV, very important. If it's bipartite, tripartite, unipartite. So every aspect of RV cavity, overall RVH, how much is the RV cavity available, all those things are important. RVOT is particularly important and often neglected. You need to understand and do the RVOT evaluation in a newborn using a 12 megahertz transducer. It's something a lot of people don't do, and that's a mistake. And if you don't do that, you don't understand the thickness of muscle in the RVOT. And the true RV cavity in the RVOT actually is often much smaller than what you would see in a patient who has, if you use S8 for example, 8 megahertz transducer, you'll miss a lot of the muscle and you may think that all of it is cavity. And I've seen that happen. The true annulus size is actually grossly underestimated, overestimated by low frequency transducers. So if you have a 8 megahertz transducer, it won't pick up the fine detail of the annulus. And you have to understand that the RVOT muscle is attached in part to the annulus. So the true annulus that you see is actually much smaller. So that's important. So the leaflet structure is very important. I talked to you about dysplastic and typical pulmonary stenosis, and you can make out all the differences. NPA is important, the diameter of the branch PAs are important, the PDA is important, the shape of the PDA, all this is terribly important. Because your PDA, you may need to stent it, you may need to park a wire in it, everything you need to understand the details when you do the echo. So we'll take some cases. So I'll start off with a case, 1 month old infant weighing 3.5 kilos, suprasystemic PS, you're planning, child is blue. You're doing a BPV, annulus is 6 mm. Okay? So question, what do you want to do? Anesthesia with endotracheal intubation or sedation? People should answer. So let's have some answers from, I don't know why the chat is not coming. Yeah, okay. Anesthesia or, I don't see many people here. Sedation. So I think overall anesthesia is the correct answer really. I think that's the way it should be, but we occasionally violate that rule here due to constraints that we face sometimes, but I think it's not recommended. Okay. Now if you have a 3-month-old with severe PS with systemic RV pressures, would you give anesthesia or sedation? Here? We do it in sedation. But if your institutional policy says anesthesia, that's also okay. But you can actually get by with sedation. If you are confident about your procedure and you know how you can do it well, then you can actually get by. All right. Now let's get back to the same case. 3.5, 1 month old, suprasystemic. Okay, annulus of 6. Then, okay, axis. No, that's fine. Which one? Venous, what sheet size? 6 annulus, what sheet size do you want? So here 5, I actually agree with Soumya. It's okay to have a 5 French because you can be a little more liberal in a 3.5 kg child. You can keep a 5 French, but 4 French won't be terribly wrong as well. But 5 French will have a distinct one advantage that may be of use later on. Suppose you decide you want to stent the duct, or you're finding it really difficult to get a good guide wire position and you need a guiding catheter underneath the RVOT, then you can get a 5 French guiding catheter. So you have a little more leeway and it's better to take a 5. Okay, would you get an arterial axis? Absolutely. There's no question you would need an arterial axis, but you can just keep it for monitoring. You don't necessarily have to put a sheath into the artery because you really need a monitoring, and you can pretty much do the balloon pulmonary valvotomy without trying to do anything in the arterial side. Okay? Okay, what catheter will you use to enter RV? It's a simple question, we always do that. So RCA. So JR what? These are the JR catheters. You take it for granted. Somebody gives you something in the lab, you don't bother. We use a JR4 mostly. Which one would you use? So the important thing is to use a JR3 or JR3.5, not these catheters which are on top. But tell me, would you just take it as it is? Or you've seen me shape it a little bit so that you get rid of the secondary curves and just keep one curve towards the RVOT. Now that's important to do that, because that way you can more predictably enter the RV. Okay? So 4 French RV catheter, which we will take, not 5 French. You can get a 5 French sheath, but 4 French is much more important because 5 French is way more traumatic than 4 French. If you have 3 French, take that. That is fantastic, because the 3 French lets you have much more freedom and you feel much more safe. We don't have enough of those, but if you have 3 French, that's the best. It makes it totally safe, the procedure. Okay? So choosing a catheter, but essence is to have a catheter that has a tip which is somewhat curved, a short curve at the tip. And then what are the characteristics you're interested? Essentially, you're interested in a torqueable catheter, and I'll talk to you about it. So the key challenges then. There are 3 or 4 key challenges. Entering RV, you agree, is a challenge? It's not so easy as you think. Getting a good position in RVOT, I think biggest challenge. Crossing the valve, surprisingly, once you get a good position in the RVOT, crossing the valve actually happens automatically, but rarely you can have trouble. This is not intuitive. Ensuring that the balloon is actually across. Now, people don't realize that, and I'll explain that to you. So here is the thing about entering the RV cavity. Now, actually, I'm not able to show it so well, but I'm going to try. So if you enter the RV cavity, for example, you take a catheter. There's one way you can enter is to just take your catheter and torque it in such a way that it sort of points towards the RVOT and connect it to pressure as you do that. Okay, as you do that, and it will find its way and you suddenly see very high pressures, and you need to just keep a constant slight clockwise torque as you push it in and keep it heading towards the left, gently watching the pressure as you've connected it. So RA pressure, suddenly you start to see very high pressures. That's the technique I use very often. The second technique which we have tried is that you make it point towards the RV, RV inflow somewhere like this. And when you point it, you just suddenly, you pass a PTCA wire and then try to cross it all the way. This is not a good technique for severe PS. And it doesn't work. It's a great technique for crossing the normal pulmonary. It doesn't work very well for the severe PS. So the first technique is what I use. I keep a gentle clockwise torque and just advance it towards the RV. The third technique is what you have seen sometimes, is that we make a loop in the RV. And then as we straighten that loop, it falls into the RV cavity. So 3 techniques. So catheter alone with pressure monitoring, wire alone, I don't like that. Catheter loop in the RA and undo the loop to enter RV. All 3 techniques are in use. The big challenge is it keeps tending to go into the LA. So you need to have a slight change in direction and move it slightly differently and watch the pressures, which is what I do most of the times, and you've seen me do that. But the risk is, there are risks, and I'll talk to you about that later on. Okay, once you've got into the RV, what do? You should give a hand injection, not a pressure injection. With the end hole catheter, you won't get an opportunity to get a side hole catheter and do a proper pressure injection, not possible. Which view? Your first injection could be just a plain PA view. You can give it a little cranial tilt to get more of the RVOT profile, but keep a plain PA view to understand where the RVOT is and see the relationship of the RVOT next to the spine. And once you've done that and you know where it is, while giving small injections, you can actually get into the RVOT, at least towards it. You don't have to be precisely in it, but towards it. Important thing is you always inject with the hand. You understand, locate the details of the RVOT in the pulmonary valve and try to cross it during the, you have a visual estimate and then you try to cross it with the wire. You can get sinusitis even in critical PAs. So you have to be watchful. So when you inject, look for that. Look for coronary filling, you can get it. And if you are having that, then you have to be very careful. One, you can get into it and forcibly inject and produce a dissection. It has happened. You can even produce a tamponade. It has happened. The second thing is also important to recognize that rarely, really rarely, you can get RVDC, which is right ventricle dependent coronary circulation. Then to engage the RVOT, here lateral is better than PA. Important to free the catheter tip all the time. Keep aspirating and make sure that there is blood coming back in the catheter tip. If you don't do that, you will inject into the muscle and create disaster. ST will get elevated, BP will drop, the child will take a long time to stabilize. And you've seen that happen. Always, even if you have a good position, inject gently. Because if you inject forcefully, you can actually create disaster. So you can, the other thing I've suggested is that you can position the catheter as you fill the cavity with contrast. Then the risks are myocardial staining and heart block. Very important, two biggest risks. So if you inject into the RVOT forcefully and you're sitting inside a muscle, you will stain the myocardium, produce ST elevation, your BP could drop, there could be ventricular dysfunction, the child could do badly and it takes some time for the child to recover. Heart block is very, very common when you manipulate catheters in small babies. So the heart block can happen during RV entry, it can happen during RVOT positioning. Because you go along the muscle bundle position, there is very little cavity available, so you have to be careful about that. So, important to pay attention to your catheter. As I said, the catheter, that RCA that we use, it should have get rid of the secondary curves, use the primary curve, profile, 4 French, torqueability, new catheter, not something that gets kinked while you're talking, and it should have a little bit of stiffness. It can't be a totally soft catheter, then it won't torque. It should have memory, and it should have an atraumatic tip, which is what, if you see feel the tip of the 4 French catheter, coronary catheter we use, atraumatic tip. So all those things are important. Okay, let's look at engaging the RVOT. So this picture is beautiful because it shows you all the features of the right ventricular outflow tract in the lateral view. So if you want to engage the RVOT, you essentially, you got a catheter here in the RV cavity. Now from this, it takes a little amount of skill to slowly turn it back, and you've seen us do that. And that kind of gradual turning in and getting in is something you learn with time. You learn with practice, and you try on these slightly easier cases, and then you come to the more difficult cases and get it. And you've seen us do that in PA, IVS, in all those difficult situations. So it's very important to learn to do that. Okay, now what's your guide wire? Same case which I did, 3.5 kg child, 1 month old, 6 annulus supravalvular suprasystemic PA pressures. PTCA wire. It's just not enough to say PTCA wire. There are hundreds of types of PTCA wire. You pretty happily ask for a PTCA wire, he'll give you one with a supremely long floppy tip. You are not going to be able to get that. So, no, it can't be ultra short as well, it will have a stiff body. So you just take a regular PTCA wire that has not more than a centimeter as a floppy tip. Okay, and then what wire thickness will you use? PTCA is 014. Okay, now the cath lab technician tells you that you have only a Tyshak 2 balloon available. What is the guide wire diameter that goes into Tyshak 2? So 021 is the diameter that goes into Tyshak 2. You typically don't have 021, so we use 018. Now the important thing to recognize is that, let's say you have a situation where you only have an 018 wire and you have a Tyshak mini. you're stuck. You can't actually do the balloon pulmonary valve. So you need to know which guide wire will go into which balloon catheter. You need to think through and plan your hardware. Not go on table, cross the wire and say, oh, this doesn't happen, this doesn't work, and that's a disaster. That's poor planning, which I've seen that happen. Okay. Tip, I told you, length of the floppy segment, stiffness of the supporting part, stiffer the better. What is the best position for the valve wire? Wrong, wrong. Both are wrong. Best position. Wrong. Wrong, 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 wrong. So the answer is descending aorta via the back. Okay. If you get this position, you are on song. The wire, the catheter will not come out. The wire will not come out. And in really difficult positions, you can catch the other end and you have a really stiff system and you can take anything over it. Okay, so it's very important to recognize that if you can endeavor to get into the descending thoracic aorta, that is ideal. If you can't, this is acceptable. All right. Okay, choice of balloon. What balloon annulus ratio would you use? Now that's a very interesting question, because what used to be the traditional balloon annulus ratio recommended in most old publications? 120 to 130, okay, or 120 to 125. What is the current recommendation? Not more than 110. And the reason I'm saying that is because you don't want PR long term. So it's not necessary to really blow and destroy that valve, and you can actually get by with 100, 110, which is what I would recommend, because we don't want to produce. However, the exception is in dysplastic valves that don't yield. Then you can oversize a little bit and try to get past it. But by and large, if you have a 6 mm balloon, you can pretty much get by with 6 or 7 balloon. 6 mm annulus, you can get by with 6 or 7. You don't have to go to 8 or 9. That is incorrect. It's really not needed. So it's important to recognize that you don't oversize it as much today as you used to do earlier days. How long should be the balloon? So it's in a newborn, it is 2 centimeters. In an older patient, it is 4 centimeters, because you don't want it to slip. In intermediate, 3 can be used in some situation, but you wouldn't use a 3 in a newborn. You would never use a 4 in a newborn. You will dilate the tricuspid valve and you will dilate the distal PA, you will produce a disaster. So you would never use a long balloon, and a short balloon can give you hell in an older patient because it will repeatedly slip. So it's important to recognize your length of the balloon. Guide wire lumen I told you about, and to be aware of what is the guide wire lumen of the catheter, and they should fit balloon catheter. Profile, Tyshak Mini, Tyshak 2 are all low profile balloons, and you like that in babies. Inflation and deflation characteristics. So if you take up an angioplasty balloon, you're in a primitive sort of lab that doesn't have anything, and they have some random balloons out there, 8 mm balloon, and you start to use it for BPV. You don't know about this. What is the difference between an angioplasty balloon and a valvuloplasty? A valvuloplasty is designed for rapid inflation and deflation. An angioplasty doesn't matter. It is designed for higher pressure. So you take an angioplasty balloon and use it in a valvuloplasty situation, you can have a terrible disaster in that the balloon will deflate too slowly for you to have a decent cardiac output. It's particularly hazardous in older patients, where you have a very large volume that you need to get rid of from the balloon, and you produce a disaster. So you need to know all these things that's never kind of discussed adequately with you guys. The other important thing is to look at the balloon design. Some balloons that are labeled as 2 centimeters are actually not 2. They have two on either side as shoulders. Have you seen the Atlas balloon? It's a disaster. It's just got an incredibly long shoulder that creates very difficult situation. So knowing everything about the balloon is very important. And again, you guys need to spend more time with that process. So getting back, other real important aspect of balloon dilation is to ensure that the balloon is actually across. You got the wire here. You put this balloon. At times, what happens is that the whole outflow tract and the pulmonary valve moves backwards, and you think you've crossed it. You don't get a waist. You balloon, and you say, I was well across. and you come off. And this valve can actually reach here. And to avoid that, what do? You cross all the way into the branch PS and then come back and inflate. Always. With balloon pulmonary valvotomy, don't feel satisfied if you just pass the valve. Get into the branch PS, come back and then inflate. Just think that you're going well into the branch PS. Just, little first 3-4 centimeters into the RPA, then come back and then inflate. That way you can ensure that you don't produce this phenomenon. Danger of this phenomenon, you have a critical PS, you've got a new nice low profile balloon, you've gone to the valve, you didn't cross the valve, you pushed the valve, you inflated it, and then now you want to actually cross the valve, the balloon has lost its profile and you can't cross the valve. So this is one thing that is critical. It's very, very important to know when you're crossing the valve, and this is the way you ensure that you cross the valve. And this is a common error made in balloon pulmonary valvotomy. A very simple procedure. All right. And how do you assess the results? Newborns, on-table saturations will improve. So that's very reassuring. Pullback gradients can be done, but you don't like to pull back unless you can do it with a guiding catheter or a 2He boost attachment. Then you can have a good pullback and not lose via position. Or you can simply record RV pressures. And if it falls, you are quite happy. On table echo, you can say antegrade flows have improved, but I found it useless. I found that this visual estimates of antegrade flow do not correlate very well with clinical results in many situations. So, acha antegrade flow was seen, very good flows are seen, means it doesn't mean anything at times. At times you are fooled because it's dictated by a Doppler, color flow characteristics, your color scales, all kinds of things. So, it's very important not to get fooled by that. Okay. What is the likelihood of repeat procedure? Newborn with critical PS. Answer this question 1, 2, 3 or 4. Okay, somebody said 4, then what did you say? You said 3. Well, we've got some answers here, so 4. You don't know, that's fine. So the answer is actually 4. It's 20 to 40%. And who gets recurrence? Dysplastic valves. But even non-dysplastic valves can get recurrence. Okay. When do you consider stenting PDA? It's when you have persistent severe desaturation. Okay, so I'm not going to be able to show angios today. Let's just take another older patient situation. For older patients, you use a regular catheter, a regular 5 French or 6 French RCA. 5 French is good enough. You can use a swan. If you don't get swan, with beautiful catheter for balloon pulmonary valvotomy. So the balloon floats it up right there, deflate the balloon and it crosses. So it's a very nice catheter. Guide wire, you need to cross with the 035 thermo, but to position, you need a super stiff wire. Deep distal PA position, duct is almost never there in these situations. Balloon choice, 110%, not too much, and longer balloon. Okay, I'm going to give you some scenarios. 16-year-old, 65 kg child, severe PS, annulus is 16. And the largest regular lab balloon in your lab is 14. What will you do? So everybody answers it right, double balloon, fine. Okay, I'm going to take you to another situation. 24-year-old, 85 kg patient with severe PS, annulus is 20. Okay, and you just don't have the combination of double balloons that will get you to 20. What do you do? It's an adult lab. So you do it in in-out balloon. So in-out is tremendously useful for balloon pulmonary valvotomy. What is the advantage? If I had a choice, I would use it for every BPV in older patient. And the advantage is with the in-out balloon is that the distal end inflates first. You inflate the distal end, bring it to the level of the valve and inflate the whole balloon. The balloon will not migrate, even though it's not a very long balloon. And you get a very good result, and it inflates and deflates really fast. Works really well. The challenge is placing a stiff wire and the jalebi wire in the distal PA. It's very difficult at times. So you need to have a technique where you take the RCA very deep and very rapidly put the super stiff wire. and that way you can get a deep position. So we've managed with that kind of a technique in now. Alternatively, if there is a good kind of post-stenotic dilatation, you can have the whole root sitting there and do it. Okay, older patient with heart failure. It's a challenge. Getting into the RV when there is severe PR is actually very difficult, and you need to think of jugular axis at that point. Crossing the valve can be a challenge. So initially with thermo and PTCA in extreme cases and going from small to big balloons. The other question is, what is the most feared complication in older patient with heart failure? You guys we've been talking about it, so you know the answer. So it's pulmonary edema, and it can be completely devastating. So you have to be very careful. How do you anticipate? You measure PA pressures. You underdilate the valve, and if there is a sign that the PA pressures are going up, you stop right there and do it 48 hours later. So that's how you do it. And it's very rare, but when it happens, it kills. Okay. Older patient, who's likely to have a recurrence? Mainly dysplastic valves, but you can have an occasional patient with a normal valve have recurrence. That's not true any longer that pulmonary stenosis doesn't recur. Especially small annulus, relatively small annulus, it's important. Can he discharge from follow-up? You can never discharge a patient, that's good. And then, is PR important? Sorry, it's just, I don't know why it played up. Is PR important? Pulmonary regurgitation? I don't know. It's just... So with isolated PS also, it's increasingly obvious that we have to be careful with PR. So it's important to not overdo this balloon dilatation. I'm not able to get to that point, so I'll just take it to the. So these are the things that I went through. So it ends there actually. Essentially, it's important to follow these patients even otherwise. So these, I thought I'll just focus on some specific challenges rather than tell you all the boring details of balloon pulmonary valvotomy. I think I'm done. If there are questions, we can take some.